hallway, but out of respect for those of you that are back, I think we're going to go ahead and get rolling. Okay, as I mentioned earlier, right after the break, we're shifting gears into the healthcare side of things, and we're going to have a wonderfully engaging panel now that's about the future of the employment-based health system for benefits. So I'm going to do a quick introduction of the panel members. Moderating, we have Tami Simon from the Segal Company. Hey guys, I know I'm loud, so let's try to quiet it down. Tami Simon from the Segal Company. Paul Fronstin, Director of Health Research and Education Programs here at EBRI. Sabrina Corlette, the Research Professor from the Center of Health Insurance Reform's Georgetown University Health Policy Institute. And Joseph Antos, the Wilson H. Taylor Scholar in Healthcare and Retirement Policy, the American Enterprise Institute. And I'll get out of the way and let Tami take over. So thank you.
Thank you. So when I was called by Paul and he said, hey, you know, Tami, there's this panel that I thought you would be good at moderating. You know, it's this real narrow topic, the future of employer-sponsored health insurance coverage. You know, he and I started having some, what I would argue were some fascinating conversations, and it really led us to the conclusion that the best way to talk about this topic generally is to throw a lot of spaghetti on the wall, because you're left with a mess, which I suspect we're all going to feel in about an hour, but what sticks might actually be some really interesting ideas and certainly some nuggets for consideration. And really, some might argue that with a lot of the conversations relating to the Affordable Care Act the last dozen or so years, we are really at a time in history, some might argue the verge, of really thinking a lot about the delivery system and the payment systems that we have in this country for healthcare. And obviously, having EBRI think hard and having the members of EBRI think hard about where the employer or what role the employer should play in that is obviously very important. So the way we're going, and by the way, hello to everybody out there in TV land. I hope I look 10 pounds lighter. What we're going to do today is we're going to have Paul do some level setting. He's a great, for those of you that have heard Paul before, he's a great storyteller. So he's going to give us a little bit of the history of why we are in the system that we're in, which, as all of you know, is unique compared to every other country in the world. And he's going to set the stage a little bit, talk a little bit about the employer tax exclusion, and then talk a little bit about the benefits of our current employer-sponsored system. There have been a lot of papers, there have been a lot of research studies done that talk about the pros and cons of the system, and he's going to kind of pull those together and give us some thoughts on why it is what it is, at least as of today. Then we're going to shift gears a little bit and talk a little bit about the alternatives to the employer-based system model, and hear from Sabrina and Joe. And I think what you'll find interesting is that you're going to hear everything from talking about a single payer system all the way to just individual insurance policies and kind of everything in between. So the thought of this panel is, we're not going to tell you what the right answer is going to be. We're going to try to articulate what some of the more interesting, maybe thought-provoking alternatives might be. And for every one of the alternatives that we talk about among the four of us, each of you will probably think of 10 other alternatives and tweaks of the different systems. And that's the point. right? Because it's going to take a lot of really smart people that are very engaged in this conversation to come up with the right answer. And some of that, will be done on purpose, and some of it will be serendipity, and some of it may be the economy we're looking at, or, war has played a role in the history of health insurance in this country. So a lot of different things will lead, I think, ultimately to the right answer. The one thing that I did want to just say as an introductory comment, besides all the other introductory comments I just made, is for us to just remember that when we talk about health insurance coverage in this country, we need to remind ourselves that there are a lot of other models out there. Now, a couple of us were just debating, does that even matter, right? Does what Canada and Britain do matter? We have a completely different history. We have a different government. We are ruled in very different ways. We are a much younger country than most others. And so just comparing what other countries do really give us any insight as to what we should do. And I suppose I would argue, look, we often don't, but we should take a look at our own history, which Paul's going to talk about in a second, and think about what we can learn from it. And geez, there actually are really smart people outside of the United States of America. And to the extent that there are systems or innovative concepts that we may be able to learn from and glean some insight from, I think we should. So I would argue, yes, we should look at the other systems, but of course, not copy anyone else's, create whatever works for the U.S., given our history, our current pain points, of which are many, and also our own demographics and our own needs. So with that said, let me introduce the panel and give you a very quick, you all have the bios and the materials that you received, so I won't go into much length, but just so you get a sense of the expertise we have on the panel. First, we've got Paul, who, as most of you know, but for those of you that don't, is the Director of Health Research and Education for EBRI, and he's been with EBRI since 1993, so he's EBRI establishment and knows lots of really good war stories. So if you're interested in that, go to him because he's got them all. We've got Sabrina, who is a research fellow at the Center on Health Insurance Reforms. That's why she's on this panel, as you can imagine, at Georgetown University's Health Policy Institute. And there she directs research on health insurance reform issues. And if I gave you the list of the topics that her group covers, we'd be here all afternoon. So read it for yourself, but you can imagine it's wide. Prior to joining Georgetown's faculty, she was the Director of Health Policy Programs at the National Partnership for Women and Families. And from 97 to 2001, she worked as a professional staff member for the U.S. Senate Health, Education, Labor, and Pension Committee, the HELP Committee, where she served as legislative assistant for Senator Tom Harkin, among other very impressive resume traits here. And then we've got Joe, who is the Wilson Taylor Scholar at the Healthcare and Retirement Policy for the American Enterprise Institute, or AEI, and an adjunct associate professor of emergency medicine at GW here in Washington. He's also the vice chair of the Maryland Health Services Cost Review Commission, where he's serving his third term as commissioner. Pretty impressive. Just so you know, prior to joining AEI, he was also the assistant director for Health and Human Resources at CBO here in DC also, and held a senior position at the U.S. Department of Health and Human Services, OMB, and the President's Council for Economic Advisors. So very impressive panel, and with that, I will turn it over to Paul.
Tami wasn't completely honest with you when she shared the story of me inviting her to be on this panel, to moderate the panel. The working title at the time was 44 Years of ERISA, Let's Discuss. Otherwise, I think she wouldn't have agreed if she saw the title we wound up with. I'm going to give you, my plan was to give you a very brief history lesson on why we have an employment-based health benefit system. You may notice that we're down a speaker. So we talked about giving you a really long history on employment-based health benefits. But I think I'm going to keep it brief, despite the fact that we have time to do that. There are a number of people that would argue that we have the system that we have, employer involvement in health insurance, because of the tax break. I actually disagree with that. If you go back in history before that, there's lots of other reasons lots of other examples of employers getting involved in worker health. If you go back to the 1800s, there's examples of employers providing on-site doctors because of injuries that may have occurred in the workplace. I think those examples are are for business reasons. It wasn't because employers were, doing this out of the goodness of their heart, concerned about worker health. They wanted workers to get well and get back on the job, so there were doctors there. And then you get to World War II, and the only war story I have is related to World War II, just so you know. There are no others related to EBRI. Health insurance took off as a benefit in World War II. Why? Because there were wage controls, and employers couldn't raise wages to attract scarce workers. There was a scarcity of workers because of the war. Employers couldn't raise wages, so they started offering health insurance. I think it's as simple as that. It was a business decision. How do we be competitive in the labor market? How do we attract workers? It was a lot less costly to offer at the time. The IRS did rule in 1943 that there was that it wasn't that the value of health benefits wouldn't be counted as worker wages, so that came along with it. There was actually some confusion about that for a good decade. It wasn't until 1954 that the IRS clarified its position. So there was some confusion for a while. So I would argue that employers offer health benefits for business reasons, to be competitive in the labor market, for work because they're concerned about worker productivity. If you think about the tax break that employers get, for the most part, they get the same tax break if they took that money and gave it to workers as income. That's income is also deductible as a business expense. The only difference is that employers save on FICA. Okay, so employers do get a tax break on what they spend on and what employees spend on health insurance, but it's not as large as all income being excluded from taxation. Now that does benefit workers, and that is one reason why employers continue to offer health benefits, because their workers get a nice tax break on the value of coverage. So keep in mind the business reasons. Today being last year, which is the most recent year we have data for, employment-based health benefits are by far the most common source of health insurance for people under age 65. There are 167 million people with employment-based coverage last year, or 62% of that population, and you could see that only 14% of people under 65 get their coverage directly from an insurance company in the individual or non-group market. 22% have Medicaid coverage, and 10% remain uninsured. I don't have a slide on this, but note that the percentage of the population with employment-based coverage has been growing since 2013. It had been falling before that, but since 2013, it's been increasing. And a lot of that increase is due to the strong economy and strong employment or falling unemployment. As the unemployment rate fell, more employers added health benefits added health insurance as a benefit, and you see that in the data we've looked at starting in 2013 with mid-sized companies added health benefits. 2014, smaller mid-sized companies added health benefits. 2015, larger small companies added benefits, and in 2016, smaller companies added benefits. So it's very interesting to see each year how another group of employers added these benefits. These are small changes on a year-to-year basis, but the trend is going in a completely different direction than it was going in before 2013. So I would argue employers started offering benefits to be competitive in the labor market. Unemployment's falling. We saw the same thing happen in the late 1990s when unemployment hit 3.8% in 2000. And leading up to that, you saw more and more employers offering health insurance as a benefit. We're revisiting that history right now, and I think it's because of business reasons. I mentioned the tax break already. The tax break, basically health insurance premiums are excluded without limit from workers' taxable income. That means they're federal income tax, it's excluded from federal income tax, excluded from state income tax and payroll taxes for Social Security and Medicare. It's the largest tax break in the federal budget. In 2018, it's been estimated about $272 billion will not be collected in tax revenue because of this tax break. Okay, that's larger than the tax break that retirement benefits get, which was only about $226 billion, and larger than the tax break on the mortgage interest deduction, which is about $41 billion. And I would note that the tax break on the mortgage interest deduction is down from $66 billion in 2017. It's a large drop. Why? Because of tax reform. But those are the big ones. But note that there's also the Cadillac tax. Perhaps the first time in history where there's been an attempt to cap the tax exclusion. It doesn't directly cap the exclusion that workers get, but it's certainly a step in that direction, a major change from our history with the tax break. This tax break has had a target on its back since at least 1980. Since the Reagan administration, and the target has been bipartisan. Both Democrats and Republicans have been interested in changing it, doing away with it, doing something in order to try and capture that money and use it to change or provide benefits or health insurance for people that don't have it for whatever reason they're left out of employment-based coverage. And if that happens, there's going to be implications. What I want to talk about is what a change may mean for government tax collections. So a lot of data on the slide. On the top half of the slide, you can see what the average subsidy is for people with three types of health coverage: employment-based, non-group coverage for those under 400% of the federal poverty level because they get the subsidy, and for the Medicare expansion population. You could also see the number of lives covered and the total subsidy. Just note that the numbers for the total subsidy in this slide is a little different than what I just mentioned before. It's $294 billion instead of $272 billion. It's in the ballpark, but basically the way we're calculating it is a little bit different than the way CBO calculates it. But all that's important for this exercise is that it's in the ballpark. Clearly, the per person or average subsidy for people with employment-based coverage is the lowest. It's just under $1,800 versus $6,100 for those with non-group coverage and just over $5,800 for those with Medicaid. Okay, so that's where we are today. If you get coverage through a job, the average subsidy is $1,785. If you get coverage through the individual market and you're below 400% of the federal poverty level, you're getting a subsidy of about $6,100. And if you got coverage through the Medicaid expansion, your subsidy is about $5,800. You can see 165 million people covered by employment-based coverage, 9 million that get subsidies in the non-group market, 12 million that are in the Medicaid expansion program, and the total dollars amount associated with it. So let's say we change things around. Let's say we did two things in the employment-based market. Let's say that we only allowed the tax break for people under 400% of the federal poverty level. And let's assume that we capped the premiums like is done in the non-group market such that you could only deduct or exclude from income premiums associated with an HSA-eligible health plan. Okay, if that was the case, 73 million people would get a subsidy instead of 165 million, and the average subsidy would fall to about $1,400 a person. In aggregate, instead of not collecting $294 billion in tax revenue. The federal government would not collect $102 billion. So presumably, assuming nothing else changes, which is a tough assumption to make, the federal government would increase its tax revenue by about $200 billion. Okay. Alternatively, let's say we move these 73 million people to non-group market. Okay, so we did away completely with the tax break for employment-based coverage. And people moved to the non-group market, and the 73 million that were below 400% of the federal poverty level got a subsidy comparable to what those in the non-group market are getting today, about $6,100. The total amount of federal tax revenue not collected, or total subsidy, would go from $294 billion all the way up to $445 billion. Okay, can we make the assumption that if we made the change, the subsidy would remain the same in the non-group market? We don't know. We don't know what that would look like. But just to get an apples-to-apples comparison, this is where we're starting out at. So, there are some real issues with the tax break. It's seen as regressive. Higher income people get a larger tax break than lower income people. It's been, you could argue that the large tax break encourages overinsurance, and that people use a lot more health care than they otherwise would because of that. Not sure how much that is true, because you still have the 80-20 rule. 20% of the population account for 80% of spending. These people with a lot of medical expenses, are they using more because they have better benefits? Maybe, maybe not. So, there are some things to think about. That the Cadillac tax may work against this. We'll see what happens there. The House, I don't know if this was introduced yet, but there's talk about delaying the Cadillac tax another year. But I think if we when we talk about alternatives to employment-based coverage, we do need to recognize that employment-based coverage comes with some strengths, and those strengths, there may be implications for what happens there. So, for example, the employment-based coverage is, you could argue that the groups that are covered are natural groups. They're formed not for the purpose of buying insurance. Therefore, it's easier to insure those groups than it would be a group that was formed for the purpose of buying insurance. And policymakers wrestle with this. If you think about the regulations that just came out on association health plans, there was a lot of concern about associations being formed for the purpose of purchasing insurance, and the Department of Labor recognized that in the comments that it received, and tried to do something about it in the final regulations. If you look at what employers do, they're a voice for employees. When an employee has an issue with its health plan, and an employer, says something in the health plan on the employee's behalf, they're not just speaking on behalf of that one employee, they're speaking on behalf of all employees. Large groups matter in that respect. If I'm buying insurance directly from an insurance company and I have an issue, I don't know that the insurance company would be as responsive to me individually as they would to an employer who's speaking on behalf of, whether it be 50 employees or 500,000 employees. So that's something to keep in mind. And employers have I would argue, been innovators when it comes to health plan design and healthcare delivery. Examples include value-based insurance design, centers of excellence, health reimbursement arrangements, reference pricing, pushing quality, cost and quality information. We got the Leapfrog group because of a report related to quality, and it was employers behind the formation of that group. Wellness programs, and even today we're talking about financial well-being, which has a major health component to it. So let me just note, I do want to put on my Rob Andrews hat, because unfortunately he's not here, and just try and do justice to what we asked him to talk about. Rob is the head of the Health Transformation Alliance, which is an organization of 40-plus large employers. They came together 4 or 5 years ago because what they saw happening was a lot of consolidation in the delivery of health care. Consolidation among insurance companies, among providers of healthcare services, among PBMs, And they thought they need, as a group of employers, they need to get bigger just to stay even with what was going on in the broader market. But I think more importantly, they didn't abandon ship. You know, they felt it was important for them as a group, for them as employers, to remain in the employment-based system, to continue to offer coverage. Because, you know, right now it's actually relatively easy for employers to stop offering coverage. For the first time in history, the Affordable Care Act gave us an alternative to employment-based coverage. Any worker could go to the non-group market and get insurance. If you're below 400% of poverty, you get a subsidy. And if your employer doesn't offer you affordable coverage, that's an option that didn't exist, and employers didn't take it. Maybe they didn't take it because of business reasons, because they feel that they need to offer coverage to be attractive in the labor market. But these employers are, if you think about it, doubling down and saying we need to stay involved. There are some real positive reasons for us to be involved in employment-based coverage, and he was going to talk about that vision. So I think that's something we need to keep in mind as we talk about whether or not, as we look at all possible alternatives to employment-based coverage and whether they would complement the employment-based system or completely scrap the system. And let me just close by noting that what other countries do does matter. Okay, why does it matter? Because large companies in the U.S. now operate globally. They're operating in these countries. They see how these other systems are working, and those other systems may not be what we need to adopt. But I think what it means is that they're more open than ever to changing around what we do today, because they see that, you know, we're unique. We're the only ones that do what we do. They see alternatives that are working for their employees in other countries, and I think that they're open to examining those alternatives. So thank you. Look forward to Q&A.
Thank you, Paul. Sabrina, how's it going with your 12 cough drops there?
Yeah, I just want to say I love this audience already, because I had about 3 people come up and offer me cough drops. So apologies in advance for my voice. I'm going to try to get through this. And I am, as Tami indicated, going to be throwing a lot of spaghetti at you, because I've been asked to talk about some of the ideas on the Democratic side of the aisle that for health reform and universal coverage that will undoubtedly have an impact on employer-sponsored coverage. And certainly the proposal that's getting a lot of attention right now from the media, industry, as well as the progressive grassroots is Senator Sanders' Medicare for All proposal. But you know, that bill is actually only one of a pretty broad array of ideas and concepts and bills that have been put forward on the Democratic side of the aisle. You know, that bill is getting attention for good reason. It has a lot of grassroots support behind it. It also would produce the most dramatic upheaval and change for our healthcare system. But it is by no means likely, and I would actually argue it's highly improbable, that the Democratic Party will coalesce behind Medicare for All in 2020. I think instead it's more likely to be one of, or perhaps a combination of ideas, progressive ideas that have been put forward. And these ideas really, in terms of thinking about them, I think it's helpful to think about them as a continuum that sort of represents a range of approaches to government involvement in healthcare, financing, delivery, et cetera, with Medicare for All being at one end, sort of the complete government as a single payer, where everybody is in the same program, to the least amount of government involvement represented perhaps by Senator Warren's bill, which would sort of build on the ACA and try to improve the ACA. So I'm going to tick off some of the ideas that are out there on the Democratic side of the aisle that fall along this continuum. I don't have time today to do all of them justice, so I'm just really going to tick off some of the high points and talk a little bit about what they may mean for the employer-based system. In all cases, these proposals share a common goal, which is trying to get us towards universal coverage and an implicit recognition that the Affordable Care Act has failed to achieve that goal in many respects, not the least of which is the fact that 30 million people remain uninsured. So what are these proposals? At the one end of the continuum, we have bills like Senator Warren's, which is called the Consumer Health Protection Act, and really just builds on and tries to improve the current system, the ACA. It addresses one of the biggest complaints that people have about the ACA, which is the affordability of coverage in the individual market. It largely improves the subsidies that people would get, including those folks who fall off the subsidy cliff. They're just making a little bit too much money to be eligible for the ACA premium tax credits, but they still find those premiums in the individual market to be unaffordable. Warren's bill also includes some insurance reforms to try to improve the benefits and the value of coverage in the individual market, but probably wouldn't have much of an impact on the employer-sponsored system, except to the extent that if it's making coverage in the individual market more attractive, there could be some employers on the margins that either drop their group plans or maybe even offer an HRA instead of a group plan. Moving along the continuum, there's been renewed interest in what I'm sort of calling as a general label, the Medicare buy-in ideas. Medicare buy-in, of course, is not a new idea. It's been kicking around Congress for many years now. But the latest iterations, represented, for example, by a bill by Senator Stabenow and Congressman Higgins in the House, would essentially allow near retirees, 50 or 55 to 64, to buy into the Medicare program. Of course, with all of these proposals, the devil is very much in the details about what the premiums would look like, who would bear the risk, et cetera. But with respect to ESI, probably not a ton of impact. Employer-sponsored retiree benefits, I think, are all but extinct, or close to extinct at this point. So probably not a huge impact on ESI, except to the extent you have employees that may be considering early retirement. Access to health benefits is obviously a big consideration in that decision. It could prompt more people to take up early retirement. Next, you have your public option proposals, and there's various iterations of those, too. Folks might remember that the Affordable Care Act debate back in 2009 and 2010 included a debate about whether there should be a, quote, public plan option marketed alongside private plan options in the marketplaces. That idea was left on the cutting room floor, but it is still under active discussions, not just at the federal level, actually, but in a number of states. But today we have bills from Senator Kane and Bennett, Congresswoman Schakowsky in the House, and their proposals would make this public plan option available to individuals and small businesses through the marketplaces, but not for employees with access to large employer health coverage. There are, however, proposals such as Senator Merkley's bill, the Choose Medicare Act, that actually would, for this public plan option, would allow large employers to either choose to purchase the public plan or, if they're self-funded, to use the public plan as their TPA. I think obviously that approach, we really could see a big change in ESI and what it looks like. But again, devil is so much in the details. What are the premiums for this plan? What do they pay providers? If it's a Medicare type of a rate, are there access issues with certain types of providers? What do the benefits look like? Is it akin to what you can currently get in the employer-based market? All of these are issues that I think will really drive employers' decisions, because all of these bills are structured as choices for employers. Moving down the continuum, I think the same kind of assessment around employer decision-making applies to another idea, which is gaining traction at the federal and state level, which is a Medicaid buy-in. And this idea started actually in state the states. There have been bills in a number of states, Nevada and New Mexico and some others. But there's also a federal proposal sponsored by Senator Schatz in the Senate and Congressman Lujan in the House. And this proposal would make the Medicaid buy-in available to folks under 65, including people with access to employer-sponsored coverage. But with this bill, if it's paying Medicaid rates, which are lower even than Medicare rates for providers, again, questions arise about what does provider access look like. And I think ultimately the choice would be for the employer or the employee as to whether to continue to offer group coverage or to make this option available, the Medicaid option available to employees. But a potential market of 212 million people, this could have a significant impact. And then this brings us to the idea on the furthest left of the spectrum, which is, of course, Senator Sanders' Medicare for All. And that one is just really simple. There would be no more employer-sponsored coverage. It contemplates that everybody, 270 million Americans, would be in this Medicare-type program. Now, the 6 proposals I've just gone through are really just the beginning. I obviously haven't had time to get into the details of those proposals, nor have I mentioned a number of proposals that are out there from think tanks, like the Urban Institute, the Center for American Progress, as well as proposals from academics like Jacob Hacker at Yale. Right now, what we have is just a lot of ideas about health reform and how it should be done, and we have policymakers and potentially future presidential candidates all jockeying for a seat at that table. But there's considerably more work that needs to be done to study the implications of these proposals, particularly for the 150-odd million Americans who rely on their employers for their coverage. It's nearly half the population, and as you all well know, it's one of the most popular benefits that employers provide. So it really remains to be seen which of these democratic ideas will emerge. And of course, with the 2020 presidential campaign right around the corner, there are real political decisions that have to be made about what happens to ESI. I mean, many of you may recall during the Clinton health reform debate, the Harry and Louise ads. People do not like to lose something that they're relatively happy with. So if I had to guess, I would guess that where we ultimately land in terms of where the Democratic Party ultimately lands is something that does the least amount of interference with the employer-based system as possible. But time will tell. In any event, a lot more work needs to be done, both in terms of educating policymakers and stakeholders, and really sort of studying some of the downstream implications of what these proposals would mean. Thank you very much.
Okay, well, so Sabrina had the distinct advantage that she could talk about what Democrats are thinking about. Republicans aren't really thinking about health policy right now. 2017 wasn't a very good year for Republicans in terms of health policy. Yeah, they basically clobbered themselves over the course of the year, and they're resting comfortably now on the canvas, at least in terms of health. These kinds of big health policy ideas. Certainly, any politician would be a fool, whether they're a Democrat or a Republican, to directly take on the big institutions that finance healthcare, which includes obviously employer-sponsored coverage, but also includes the Medicare program in particular. And so I think to some extent the focus of a lot of discussion these days sort of misses the fact that there are a lot of other policy goals and a lot of other considerations than simply expanding coverage or expanding benefits. As Paul said, employers are in this game for business reasons. Well, politicians are in this game for political reasons, but they're also business reasons. It really does boil down to whether a policy gives you an advantage in terms of cost or in terms of political popularity, and less so the high-sounding phrases like coverage for all. That's a great phrase. Medicare for all is a great phrase. These are great phrases, but they don't necessarily mean anything. And as Sabrina said, and I completely agree, Democrats will be struggling to figure out what they want to say. Specifically, details matter, absolutely right. And Medicare for all might not go away as a phrase, but what it could eventually turn out to be, I think, is a good question that nobody can answer, Democrats, Republicans, or anybody else at this point. Tami started us off by raising this idea that there might be a right answer. And I was thinking, well, right answer for what exactly? So, and this gets back to my point that there are a whole bunch of policy goals that one should consider. So if we're looking for the right answer, what are we looking for? Well, we're looking for a right answer on cost. We're looking for a right answer on coverage. How many people are covered? How many people are not covered? We're looking for a right answer on access to services, which is not the same thing as having an insurance card. We're looking for the right answer on innovation, medical innovation. We're looking for the right answer on the balance between how much we're spending on healthcare and everything else. Well, I'm not so sure that we can look across any ocean or any small body of water, thinking of the Great Lakes, and necessarily find an answer for us. In fact, I think if you look across a big body of water, you may not even find the answer for them. The fact is that it may be more obvious in the case of Britain because we get more information about the National Health Service than we do about France or Germany or the other European countries. But the fact is that there are constant adjustments in those systems, just as there are constant adjustments, just not necessarily done through the government in the U.S. system. So I wouldn't argue that there is a right answer, but there are lots of trade-offs, and that's the point that I think is easily slid over by politicians. They want to say, we're going to give you fill in the blank, whatever your favorite phrase is that sounds good, leaving out that, A, it's going to cost somebody something, it might even be you, B, you might have to give up something else that isn't financial that you really care about, and I'm thinking here about access to providers. As some presidents have been known to say, you can keep your coverage if you want it. Well, that's actually a good political statement. Medicare for all, Bernie's plan wouldn't allow you to do that, and I think that's an issue that's going to be a problem for Democrats if they take this seriously. So what can I say about where Republicans or possibly conservatives might fall in all of this? No, they do not want to substantially make changes to the employer-sponsored system. In a sense, one of the biggest tools is now gone forever. The ACA, the people who wrote the ACA were really very, very smart, both technically and politically. So why the Cadillac tax? The Cadillac tax exists because you can tax those mean insurance companies, but you can't tax employees. You can't tax employers. But those insurance companies, we hate them. All we know about them is they make us fill out forms, and then they don't give us all the money we imagine we're supposed to get. So that was really smart. That took all of the political air out of capping the exclusion or making other adjustments that might actually be more equitable in some ways. So I don't expect the Cadillac tax to go away, but I don't expect it to ever be actually implemented, because as a political matter, you see, it's perfect. It's like checkmate. None of the pieces are going to move anymore on this particular chessboard because you can't do it. Republicans and Democrats alike are aligned on at least one thing in healthcare, which is they don't want to see that tax ever go into effect. And so it probably won't. Where else are we in all of this? I do want to say something about cost. I think this is where I would hope that large employers would show more leadership. They've begun to show some leadership in terms of adopting ideas that could slow down cost growth. And I have more hope that employers could point in reasonable directions than the government. And by government, of course, I really mean the Medicare program. And the reason I say that is that the Medicare program's entire history, with one exception, entire history of cost containment has been to change basically pricing, change the update factor for hospitals and physicians and everybody else. Occasionally wiggle around the payment ratios, claiming that they're doing one thing when they're actually doing the opposite. But the reality is that there hasn't been a lot of large-scale cost containment in the Medicare program. And if you can't do it in the Medicare program, which is wholly owned by the federal government, then you probably can't expect the federal government to do it elsewhere. Now, what's the one exception? Well, the one exception, I would argue, is, in fact, the Part D program. And it has a characteristic that is not possessed by the rest of Medicare, and that is that in 93? Yeah. 2003, sorry. I'm still living in the past. In 2003, or maybe in 2002, when they were thinking about instituting a drug benefit, that, by the way, people talked about a drug benefit since probably before 1965, and every time it was, it's probably going to be too expensive. But anyway, so this time there was some willingness to actually do it. But what they did was they said, well, we don't want to make it like the rest of the Medicare program because that hasn't worked very well. And instead they went to private plans. Now, you could argue about whether the competition is very robust there or not, but the key element isn't that. The key element is that a private plan, as long as you have multiple plans to choose from, a single private plan can say no. They can actually say, no, we're not going to cover that, or we're going to raise the cost sharing on a drug that you want, but there are other alternatives. And if you don't like that plan, you can go to another plan. With a national program, it's very difficult to say no. That is the history of the Medicare program up to 2005. Now, unfortunately, I think we're probably headed in that direction. I think there's been so much attention to some misunderstanding about drug cost and drug pricing that we may actually be on the way in the next administration, and I'm maybe predicting the outcome, at least in terms of political party, but we may be on the way to actually taking the one tool that has worked to limit cost growth in a major part of the Medicare program. So that's a real problem. Anyway, big employers have tried. Why have they tried in the last 10 years? I would say that they've really been working on cost issues. It's because when costs get big enough, then it's no longer the job of the HR director. It's the job of the CEO. It's the job of the board of directors. Until there's focus, until there was focus like that with big employers, basically nothing much happened. On the other hand, I've got to argue that that wasn't wrong, because the other view should be that this is just a cost of doing business. You're going to hire employees. What are you going to do? Nickel and dime them? It's very difficult. You have to come up with a better idea than using what is essentially the Medicare approach to controlling cost. Doesn't work. Didn't work for Medicare. Wouldn't work for employers. And so I would argue that ideas that Medicare claims they invented, but they didn't, such as reference pricing, and directing employees with back problems to a center of excellence. The point of which is not to save money on the surgery, but to save money on not doing the surgery. Those kinds of ideas make a lot of sense. Big employers have tried to do that. Is there enough scale? Can employers do this on a nationwide basis? The answer is no. Even a very large employer, unless they're heavily concentrated in a geographic market, doesn't have a lot of sway with regard to insurers or with regard to providers, and in particular, hospital systems, which have tended to consolidate pretty vigorously. So I guess what I'm saying is that my hope is that employers will show us the way, but I'm mighty depressed about that too.
Thank you very much. I thought these were outstanding throws of spaghetti, and I'm sure all of you have your own versions of that. The one thing that I think is really interesting that none of us really talked about, and I realize what the title is here, right? We're talking about the employer-based system, but we all really focus a lot of attention on the way cost is focused and the payment system, and none of us, although Joe, you did mention the UK's National Health Service. That's actually their delivery system, right? Their doctors are nationalized and they're working for the government. And so I think, Sabrina, when you were talking a little bit about well, if we do Medicaid, the reimbursement rate is lower than if we do Medicare. So just sort of an observation that when we're talking about how things are paid for, how services delivered may also be, or should probably also be, a piece of that conversation. And I think a lot of folks have mentioned that, especially when the debate was occurring after PPACA first passed, and then it evolved into what it is today. So I don't know if any of you have any questions about that or comments on that before we take other questions from the audience.
No, just this is sort of picking up on what Joe was saying too. I think if employers' hair is not on fire about costs, it should be. We're looking at trends where the rates paid for commercially insured patients, the provider rates, the growth of that is outpacing what Medicare pays. So, if on average it's 200% of Medicare rates, we're seeing areas where it's 300%, 400%, 500%, and growing. And that is simply unsustainable for employers and for our system as a whole. So I think some of the, while I certainly, and I can't speak for Democrats at all, we're nonpartisan, but I do think that what is interesting about some of the Democratic ideas is while they are conceptually and about universal coverage and let's get everybody covered, a lot of them are talking about really changing the way providers are paid, whether it's Medicare rates or Medicaid rates or pegged to some sort of standard rate setting system. And so it's maybe a backdoor way of getting at costs. But I think something that we need to be talking about those trade-offs, as Joe mentioned, and what they mean. But I think there's unanimity on the fact that where commercial rates are going is not sustainable.
So actually, my immediate thought when Tami made her statement was, gee, the military draft wasn't very popular either. So I don't think we're going to draft doctors. But the fact is that the leverage is financial. Now, of course, we could also talk about other issues, including standards of practice and business structures within the healthcare sector. It's kind of complicated, but the fact is that this is not the legitimate province of federal policy. Federal policymakers really don't know that much about how to run a hospital system or a health system. They really don't know very much about how Medicare operates. At least the people who work on the Hill don't. And they oftentimes don't realize that Medicare operates primarily through private contractors. The policy end of it obviously operates out of Baltimore, but the nuts and bolts of how do you get a bill paid operates through they used to be private insurance companies, and now they're other kinds of private contractors. So you can't really separate out in some clean way a government system from the technical capability to do what is necessary to get the bills paid, unless, of course, you change the entire basis for paying bills. And I have to say that often conservatives and Republicans will say, oh, capitation is the answer, but these are the people who don't understand that capitated payment systems still pay doctors to some extent on a fee-for-service basis. So there's no magic bullet out there, unfortunately.
Okay. So questions from the audience? Yeah. If you could please come up to the mic so the folks in TV land could hear you, that would be great.
Okay, we had a heated discussion about medical issues last night, and I won't repeat that, but I feel like, I mean, this conversation, you said that you shouldn't be copying other countries, and I agree with that. There are no perfect solutions out there, but there are different solutions out there. And one thing that keeps coming up here is this sort of Medicare for all, Bernie Sanders, National Health Service, doctors employed by the government. That it's a lot more nuanced than that. So I think there are two things that you need to do in the US. Okay, sorry. I would do here if I could sort of wave my magic wand.
You're from Texas, right?
Yeah, sure.
Yeah, okay.
I can do my Texas accent. Well, I can't actually, but no. But sort of basically, first of all, you have the problem of sort of coverage, and then secondly, you have the issue of costs, right. And they are related to each other. And then the third thing that keeps floating around here is the sort of idea of should it all be done by the government. Now, it doesn't have to be done by the government, and in fact, in most countries, it isn't. So you have your sort of National Health Service equivalent, and yes, that's the sort of government-funded thing. But that doesn't mean that you don't also have a private sector. It doesn't mean that you don't also have employer-sponsored health coverage. What it means is that everybody is covered on a basic level by the government, and usually what happens is things like if you get cancer, that's covered by the government. Childbirth, hip replacements, you know, the big things. They are usually taken care of by the government system. But then you also have a private sector. And by virtue of having a government system that is virtually free to most people, that really pushes down the cost of the private sector because you have a basis of comparison. You can, if you have something that's non-urgent, you can decide, do I want to wait six months to get my ankle fixed? Or do I want to pay to have it done privately, quickly? But that sort of puts a cap on how much you're prepared to pay for it privately. So that, I think, is the first thing about having universal access, even if everybody doesn't end up actually using the government-sponsored system. It really brings down the cost of the private sector alternative. A second thing that totally mystifies me here is the lack of transparency. So I've actually spent most of my adult life in Finland. There, if I want to get a mole removed, for example, you know, I don't need to be a sort of patient in a medical practice to be able to get it done. I can just call around all the different health centers and say, how much will you charge me to have a mole removed? And they'll say, oh, we'll charge you $100, we'll charge you $50, we'll charge you $200. And I go wherever I want. Here, when I called my sort of medical provider and tried to ask about how much a procedure was going to cost, they couldn't tell me.
They don't know.
Yeah. I mean, there is sort of, I mean, what other things do you have here? If I go to Macy's and want to buy some jeans, they have to tell me what the different sort of kinds of jeans are going to cost. They can't say, I don't know, you pick something and we'll tell you later how much you end up paying for it.
Right.
So, I mean, just to sort of, I mean, I don't agree with Bernie Sanders. I think that sort of you should have the eligibility to healthcare for everybody, but it doesn't mean that you only have a single payer system. You can have a sort of much more nuanced model, but you just need to have the sort of ability to cover everyone, and then you need to sort of have transparency for costs too, because it's so opaque now that no one can really compare providers. Okay, I'll get off my soapbox now.
So, yeah, you make a lot of good points. It's not that you find out the price after you bought the pants. You got them altered, and then you found out the price. It's too late. So, yeah, you're right about that. But again, you know, we have to start from where we are, not from where we're not. And that's really the hard part. one thing you said, though, that is commonly said in the United States, which is, therefore it's cheaper. No. Therefore, the system is financed through another system, speaking of non-transparency. If you're talking about Britain, it's probably largely financed through some general revenue scheme. I'm not exactly sure. But the point is, it's not cheaper.
What it is, it costs half as a share of GDP compared to.
No, but that's a slightly different story. My point is that in this country, people hear this and they think, oh, okay, it's going to be cheaper. But remember, we're starting from payment rates to doctors and hospitals and everybody in the health system that are 50, 60, 80% higher than in Britain or in Europe in general. And so if you move to that kind of a system, several things will happen. First of all, it won't pass through Congress because the medical lobbies are too strong in this country, A. B, if it did, then you would find what we've found in the Medicare program, which is whenever Medicare reduces its payment rates to various services, we see an increase with not too much of a lag in utilization. Not necessarily one for one. It doesn't necessarily happen all in that one space, but we see utilization at a higher rate. And so, again, this is the kind of thing where it's easy to fall into the big think kinds of phrases without asking yourself, how would you make it work here? How would you get from where we are now to somewhere else? And going back to the theme of the conference, do employers have anything to say about it?
I think we have maybe time for one more question. Go ahead.
Well, I just want to reiterate part of the employer community is consumer driven. It's being pushed, part of it being the Cadillac tax and employers looking at that looming if they offer too rich of benefits, so they've moved to these consumer driven. But the consumer doesn't know the price before they're purchasing. So as a pretty large employer group trying to be involved in that, there is that reluctance from the medical community to disclose their price. And so then you've got the consumer side saying, well, how do I know? How can I make that informed decision of whether I'm going to pay $50, $70, $200 based on quality of care? So I think the employer market is wrestling with how to even that playing field. I think they want to stay in for a business reason, to retain good employees, keep them healthy, all of those good reasons. But it's also one of the biggest ticket items on their bottom line that they're paying for, and the cost is out of control, and no matter what they do, they have no real say in that provider world. And the provider world's frustrating. When I talk to my providers, are like, I got like 20 different rates depending on which carrier it is or whether it's Medicare, Medicaid. And so they've got that frustration of, and I said, well, why don't you publish your prices ahead? So the consumer knows if they're uninsured, this is the price. If you've got insurance, this is the price. So I think I know there's reluctance, Joe, you said, because of the AMA, but consumers are frustrated and employers are frustrated. Right, exactly.
But you realize that you said the magic words. It depends on what insurance you have, right? Okay, so it's not so much whether a hospital, nails their so-called list prices, which nobody pays, by the way, to the front door of the hospital or to the door of the emergency room. That's perfectly irrelevant. What is relevant for people with insurance is knowing where they are in terms of satisfying their deductible and so on. In other words, the information it's not a simple price. Now, it could be. I'm not saying that if we had an entirely different system that it couldn't be that way. But what I am saying is that it isn't that way. So the question is, how do you make it more transparent? It seems to me that the age of computers is going to be something of a solution for us eventually, because you can tie together information on an individual basis from the insurer in terms of where you are on the cost sharing schedule with information about what the insurer pays, who's in the preferred provider network, who isn't, and so on. We could get there eventually. It's awfully complicated. Certainly, if it was a simple unitary system where all doctors accepted and all hospitals accepted government rates, it would be easier to understand, but it wouldn't necessarily be a cheaper system, it seems to me.
So just a couple quick things. One is I grimaced a little bit, Joe, when you said computers are going to save the day, because I think we've been talking about health information technology and electronic medical records for what, 25 years. I still have to get my doctor to fax me stuff. We don't have a fax in my office anymore, and so I have to, like, it's just impossible. Anyway, that's a separate tirade. I will say that I think many employers have been shifting to what's called consumer-directed healthcare or higher deductibles, simply as a way to manage the cost growth. But I am getting the sense in a lot of places that that's been maxed out. Consumers, employees are sort of at the end of their rope when it comes to the cost sharing they're exposed to. And I think many employers are feeling they cannot keep pushing high deductibles as a cost containment strategy. So then what? And the problem is that there's a fairly limited set of viable options. The most obvious one, particularly in the face of higher provider prices, is to narrow your network. We will not contract with this high-priced hospital. But I'd be curious for a show of hands for those of you who are buying benefits for your employees in the room. How many see that as a legitimately viable option where you're going to tell your employees, we are not going to let you go to hospital X, even though it's the marquee hospital in our town? I mean, it's really hard to do. And I've talked to HR folks who just said that is the third rail. We cannot go the narrow network strategy. Well, if you can't do that, there are a very limited set of tools in your toolbox, and they don't get you very far.
Okay, so Michael, you're ready for me to wrap up? Okay. There were like lots of people right after that were like, oh, wait. But I think we'll have to privately after, because I know a lot of people have lots of places to go. So thank you. This is clearly just the tip of the iceberg on this conversation. And if I were just to make one recommendation to EBRI, it would be to continue to have forums where those of us in the community that we are in keep talking about this, and EBRI actually help us be a leader in some of these conversations as well. So thank you all for coming, and I turn it over to you, Michael.
Thank you, Tami. Tried to get all those questions in, but I know we're at lunchtime too. So we are officially about 10 minutes late. We're still going to end lunch at 1. It's just up the hall. So if you want to grab your lunch and mingle and do some networking, Kevin's here. We'll have Kevin Madden on from 1 to... is it 1 or 1:15? 1:15 to 1:50. So your lunch is until 1:15. Back here at 1:15 for Kevin Madden's presentation. Thanks. Thank you all.